Thank you everyone for this opportunity. Look, I've got 15 minutes to talk about scoliosis, so I'm just going to really talk about how to broadly assess it and look at it, and some of the things that we're doing at Sydney Kids which are novel. So hopefully it's an entertaining talk for you all with some good take-home messages. So what is scoliosis? Everyone tends to think of scoliosis as a sideways curvature of the spine. King classically described 5 sorts of patterns, and you might think of those long C-shaped curves, those double major type S-shaped curves, and or other. It can occur in the thoracic spine, the lumbar spine, or both, and even up into the neck. So in reality, the real question is, does a patient have scoliosis? Is there a structural curve, or do they have what we call a list or a listhesis, where they're standing off to one side? And here you can see 2 gentlemen, and one has a scoliosis and the other one has a list. And the real classic way to test this is the classic forward bend test. So what you see with the gentleman on the left is rotation. So the spine is a segmental structure, and you get intersegmental rotation, and on forward bend you can either see a chest wall rotation or a lumbar rotation, or you might see both. What you see with the other gentleman is no rotation. So why is he standing off to one side? Well, he has an adolescent lumbar disc. So he's got a painful side of his leg, and so he moves away from it to open up the foramen and the nerve on that side. So when I look at scoliosis, we tend to classify it now with early onset versus late onset. Early onset scoliosis happens in children less than 10 years of age, and late onset in those older. So the earlier it happens, the more likely it is to be something that they're born with, associated with a neuromuscular cause, or a syndrome such as neurofibromatosis. The adolescent idiopathic scoliosis is the classic cause of adolescent or late onset scoliosis. The reality is idiopathic is a whole phenotype that is scoliosis, and we just don't know the cause. There will be a collection of causes, whether it's genetic or otherwise, but we just haven't defined it. So I hope this portrays quite well, but here you can see a very young spine, and what you can actually see is an extra hemivertebra in through here. So this is your spinal segments through here, here and here, and this is a congenital form of scoliosis. Not only can it occur as an extra on the front view, but also as an extra on a side view, so you can have a wedge. So why do we worry about it? Well, it happened when the child was in the mother's womb, usually somewhere at about the 4-week mark. There's a range of onset. So the real problem is what else is going on. And that's the main thing that will affect their health long term. We're actually seeing patients diagnose this with intrauterine ultrasound at the 18 weeks and coming in to see us early for counselling. So up to 40% will have spinal dysraphism, and this is where there's an abnormality of the actual cord, whether there's a split cord, a failure of formation of the posterior elements. And you might see this with this baby, where they've actually got a very low-grade type of spina bifida to a full-blown malar meningocele. The other system pathology that can happen is up to 40% will have kidney anomalies, 10% will have cardiac or other tracheoesophageal anomalies and need early surgery. They can have anorectal anomalies, limb anomalies. And why do all of these happen? It's because you get this folding at that time, and anything that's in the midline can be affected. So syndromal scoliosis, what does this mean? It's a clustering of scolioses that occur in association with other syndromes. The classic one is Marfan's. It can be Ehlers-Danlos. So these are connective tissue disorders, and they tend to have ligamentous laxity. They can also have rapidly progressive curves. So treatment for these children include bracing and or surgery. Here's a gentleman with known Marfan's, and he's a very good swimmer. He didn't have scoliosis. So neurofibromatosis is one of the curves that we tend to worry about. They can have a long type idiopathic curve, or they can have these very short focal curves. The very short focal or short sharp curves are the ones that can be at risk of having acute cord compromise, and they're both technically challenging to fix, and they can also have a higher risk of perioperative neurological complications. So these ones are very technically tricky. So one of the main things that I would like to talk to you about today is neuromuscular scoliosis. There's a long list of causes from early, such as spinal muscular atrophy, through to cerebral palsy, which is by far the most common cause that we're seeing and or needing to operate on today. Duchenne's muscular dystrophy tends to actually be one of the more historical causes, as high-dose pulsed steroid treatment seems to be preventing a lot of scoliosis in these children. So it tends to be a long, collapsing C-shaped curve, and here you have a child that's actually quite malnourished. So these days, children tend to be very well fed. They're often nutritionally supplemented with PEG feeds to help minimise their aspiration risk. And what you've got is significant costopelvic impingement, pelvic obliquity, and they're unable to sit upright. So we offer surgery to family and carers if they feel it will improve their quality of life, if they're having pain, and if the patient's going to be able to be fit for it. So why do these kids get scoliosis? Well, it's a truncal coordination issue. They have muscle imbalance and weakness. They may have increased or low tone, and they'll have a neurological drive associated with this. They have poor posture and poor truncal control. Although this is variable, some children do have good truncal control, and it's one of the things that we assess. There's an increased risk of progression in those who actually come in with a coronal Cobb angle, or the angle that measures more than 40 or 50 degrees, and if they tend to sit in a wheelchair for protracted periods. Now, that may or may not progress rapidly. You only know with time, and so we generally tend to assess these patients annually or over 6 months if they're going through rapid phases of growth. So what also makes it more difficult is if they tend to get a hip dislocation on the same side. If you have a unilateral hip dislocation, your hip comes out, you can imagine the pelvis is actually tilted even more, and then that will make the scoliosis progress quite rapidly. And those tend to go hand in hand, and they come in with both. We do tend to do the spine first. So in these children, scoliosis is progressive even after growth, and that's because they tend to be non-ambulatory. So treatment options, who do we offer bracing for? A DMO or second skin is very good for those long floppy curves that tend to be hypotonic, that need help sitting up, and they tend to have a sideways bend rather than a scoliosis that's significant. You can do cutouts for PEGs for them, and they don't tend to impair their lung function either. Asymmetric wheelchair supports for those that tend to slouch to one side or having problems sitting up are things that can be considered, and we work hand in hand with many of our allied health departments in this regard. So bracing is something that we can consider occasionally. Surgery, we tend to do growing rods or fusionless surgery currently, and that's one of the new techniques that I'd like to talk to you about. The traditional technique is a long posterior spinal fusion, and you could do a front and back, you could do just a posterior, and the other consideration is whether or not you need to go to the pelvis. So our non-operative and our operative aims are actually the same. What we really want to do is get these children sitting well, have good spinal balance, and ideally offer a safe treatment option that maximises their lung function, maximises their quality of life, maximises their gastroenteric feeding, and minimises complications. So here we have an option of a traditional type curve. Whilst I was at Starship last year, we did an assessment of all of the cerebral palsy patients, and they actually had very good outcomes with a less than 1.5% intraoperative mortality rate, and that's perioperative up to 30 days. So what we've got is evidence of a long collapsing curve, a tilted pelvis, and here you have a long-term follow-up. So you tend to fuse them from the top down to the pelvis to get pelvic control, and that's maintained long-term. You only get a 50% correction if you measure the absolute numbers, but that's not our aim. Our aim is to getting them sitting up and have good quality of life, okay? So why have we changed? Because we know it works. We know that parents are satisfied, we know that they're happy, we know that if the children survive the initial operative outcome and the course, that they tend to do quite well. Well, the French have kept this technique hidden for more than 10 years, and they're doing this fusionless type surgery where they do a iliosacral screw and a construct up the top. I'll show you a picture. But they're getting the same correction with far less complications and far shorter hospital stay and much less bleeding. So this has got to be better for these frail patients. So that's what the bipolar is, and it really is just a north and south pole and then these tunnelled rods connecting. The tricky bit is that funny little screw down the bottom through here, and we tend to use CT navigation to make sure it's safe for the patient because we're actually doing an outside-in technique. Over time, If you don't quite get the correction that you want and the patient's well, you can actually go back 6 to 12 months later. And the benefit is that you use that viscoelastic time and stressor to actually continue to correct the spine and the pelvis. So what's the benefit and the risk? You get a comparable COB correction. That's just an angle. It's a number. It's not really what we're interested in. You get a better pelvic correction. You get better seating balance and decreased complications. The risk, we're not fusing it, so those rods can break. So there are some technical things that you need to think about. It's very unusual for these patients to be obese or overweight, but anyone that is will do 4 rods up to try and prevent any problems. And also some of our patients have a dystonic type of cerebral palsy where they have abnormal movements, and for those patients we'll also use the 4-rod construct. So it allows us gradual correction of the spine, spinal derotation, and a reduction in neurological complications and perioperative complications. The French believe it avoids final arthrodesis in addition. So what about the other collection of early onset scolioses, the idiopathic forms? Well, these are the ones that we really need to watch out for. Infantile forms and juvenile forms. The infantile form tends to happen in the less than 3 and the juvenile in the less than 10. Infantile forms can be successfully managed with either casting or bracing and can be regressive. The juvenile forms tend to be quite, and I use the phrase malignant, but they can have a lot of rotation and be rapidly progressive, and they are life-threatening because they'll affect their cardiorespiratory function long term. So what we aim to do is growth maximisation strategies. Ideally, we won't operate until the patient's big enough, so ideally not until they're 8, if we have to 5, and we do growing rod surgery. And then we delay definitive fusion until their chest is actually large enough to cope with adult life. There are some surrogate measures that we use. We actually measure the T1 to T12 height, and we'd ideally want that to be 22 to 23 centimetres, and then they've got a better chance of having good lung function. It's never normal, and that needs to be iterated, but this is actually a malignant process. So your classic adolescent idiopathic scoliosis, which you will all see. The typical patient, as I say to everyone, 90% are female, 90% have a right-sided thoracic curve, and more than 90% don't need surgery. To be honest, we actually only operate on less than 5%. So the question is, who do we observe? Who do we treat? What treatment options are there, and what benefit is there? And when do we operate, and what are our goals? So this is one of the original age plots, and it shows that the younger you are, that you present with this curve, if you've got more period of growth, the worse this curve may behave. Now, different curves behave differently. So if you're 10 to 12 and you've got more than 2 years of growth left as a female, or potentially 4 years of growth left as a male, this curve's going to get worse, especially during adolescent growth spurt. So we know that 2 to 3% of the adolescent population have scoliosis. Most curves have minimal to no impact on health. There may be a consideration for respiratory and a cor pulmonale if these curves hit 120 degrees. Now, those are big curves, and that's not what most people will be seeing. So Weinstein demonstrated quite in the 1980s the risk of progression, and we still use this data today. Thoracic curves tend to progress as an adult, i.e. once growth has stopped, once those curves are hitting 50 degrees. Whereas the lumbar curves can progress once they're 35, and it's thought to be because of that increased mobility in the lumbar spine, whereas the thoracic spine is strutted by the chest. It's a little bit more rigid. So we do have different operative parameters depending on what sort of curve it is and where it is and how it's behaving. Who do you have to watch out for? Males. Any male needs a screen and or an MRI. Anyone who's less than 10. Any of those with abnormal skin lesions or evidence of midline stigmata or changes that you might be worried about. Anyone that has abnormal neurology. Any new scoliosis, as far as I'm concerned, mandates a full neurological exam. Anyone who has significant neurological history, whether it's abnormal neurology or occipital headaches. Occipital headaches are one of the cardinal signs of a syrinx or or a fluid area within the actual cord. And any of those curves that look funny or are behaving funny, that come through, that have a large magnitude, a lot of rotation, or are changing rapidly, those are the ones I'm worried about. So who do we brace? We brace those who have basically 18 months to 2 years of growth left, and it works. There was a really good New England Journal of Medicine study by Weinstein again. He's one of the spine gurus, and it showed that those who actually wear their brace for more than 18 hours a day tend to do really well, and that's just the dose-time relationship. So why do we operate? We operate on those curves that we think are going to progress as an adult. Our secondary aim is to have the patient looking good. That's not the primary aim. And we always consider what the risk of lumbar degeneration is. We try and not fuse below L3. Here's an example of an 11-year-old female who's got a right thoracic curve. These are her imaging that you'll get, and it's a full spine EOS. So these are the numbers, these are the examples of how you'll generate those numbers. The primary curve is a right thoracic curve, and it measures 76 degrees. The other curves are what we call compensatory curves. They don't have rotation, but she's trying to maintain spinal balance. What's concerning is that she hasn't. She's started to shift, so that's worrying. So she was booked for surgery. That curve was big, and it was going to get worse. We also look at the sagittal profile, and a lot of these tend to be quite flat, so that's normal. Anyone who has a really pronounced forward bend or kyphosis, that's abnormal in these sorts of curves, and that's worrying. Unfortunately, whilst she was on the wait list at that hospital, not here, she did progress, and she came in with a 90-degree curve. We did her preoperative benders, and you can see that that's rather stiff. So we had to do a lot of work at the time of theatre to actually get her straightened up. These are her postoperative results. Good correction, but really the main aim is balance and not to fuse below L3. So what's my goals? Correction. I want to decide what levels I'm going to fuse and ideally preserve motion segments below that. Maintain balance and make sure the patient's satisfied with minimal complications. When you have the really big curves, sometimes you have to go to the front. So if you wait too long and they need a thoracotomy, they end up with a front stage flip and a couple of weeks in hospital recovering. But they do well long term, and these patients are always satisfied. Thank you very much.